Professor Satish Raj is a distinguished heart rhythm cardiologist and a leading authority in autonomic disorders. After completing his internal medicine and cardiology training at Queensland University, he pursued further training in cardiac electrophysiology at the University of Calgary. His career included over a decade of formative work in autonomic disorders at Vanderbilt Autonomic Dysfunction Centre in Nashville, and currently he holds the position of Professor of Cardiac Science at the Libban Cardiovascular Institute and University of Calgary's Cummings School of Medicine. Dr. Raj's research interests primarily focus on advancing and understanding the treatment of POTS, vasovagal syncope, and orthostatic hypotension, and his contributions to the field are widely recognised and evidenced by his more than 300 publications. He served as the president of the American Autonomic Society from 2018 to 2020, and in 2014 he was honoured as the Dysautonomia International Physician of the Year, rightly so. He generously offers his guidance as a medical advisor to numerous patient advocacy groups, including POTS UK, the Ehlers-Danlos Society, and Dysautonomia International. And we are extremely thankful that Dr. Raj and his family have enthusiastically agreed to join us from Canada and come here. Dr. Raj, thank you.
Thank you for the kind introduction. Yesterday I had to follow Ali and I complained, so I appreciate them, the organizers sort of switching the schedule around for me. So it's intriguing that Marie-Claire brought up the rugby tackle, because one of the things that we've been introduced to in the last couple of days is my son's actually been watching a lot of Aussie rules football. He was particularly impressed by the guy that jumped on a guy's back and climbed up to try and get the ball. But I think it makes rugby seem rather, civilized and polite. My disclosures are listed here. I'm not totally bought and paid for. I guess I put this up, and it's actually a relevant point, because if I gave this talk a few years ago, the consulting stuff would be almost absent. And you see it's sort of broken down by some OH consulting, but importantly, there's actually a lot of POTS consulting. And what that speaks to is that in the last couple of years, there are actually a bunch of companies that are interested in trying to develop drugs mainly for POTS. So these are, based on mechanisms that we think exist in POTS. They think that there's a market there. These are at a really early stage. If you know anything about drug development, most of these will never see the light of day because they'll die on the way. But until a few years ago, no one cared. Until a few years ago, the drug research that we did was all drugs that were older than I was, that we were repurposing. Right? So I think what this speaks to is that this may be the dawn of a new era, right? There actually is interest, because ultimately, if we're going to try and come up with novel therapeutics, we need industry interested, and we're seeing that now in a way we haven't seen before. So stay tuned. Maybe the next decade, a decade from now, we'll be in a different place in terms of, really having, the industrial complex behind us, which we need if we're going to move forward. So this is a sort of an overview that's going to touch on a bunch of things, not in great detail. So if there's stuff that you have more questions about, feel free to Aussie Rules Football tackle me afterwards. So POTS. So the criteria we use for POTS largely dates back 30 years. In 1993, Phil Lowe was at Mayo, and there's a guy named Ron Schondorf, who's actually a Canadian guy that was a neurologist doing a fellowship down there, and they published a paper describing a group of patients that had isolated orthostatic tachycardia without another obvious cause. And that's actually what led to sort of a version of the criteria. It's been tweaked minimally since that time, but not tremendously so. And what they described, and the criteria we use today are basically patients that have an excessive orthostatic tachycardia. And the word excessive is important because orthostatic tachycardia is not abnormal. Orthostatic tachycardia is physiologic. In fact, the absence of orthostatic tachycardia, if you actually have no heart rate increase on standing, that's abnormal, and that probably indicates other problems that we need to talk about. But there are some people that did it really well, right? Where the tachycardia went up a lot. And importantly, this was in the absence of orthostatic hypotension, because I think we've all recognized if someone gets a massive GI bleed and they're dropping their pressure, they're going to get orthostatic tachycardia, but that's the physiologic response, right? But this was without that explanation. And one of the challenges with orthostatic tachycardia is that they said, okay, excessive based on 2 standard deviations above the normals for the healthy controls. They tilted was 30, okay, that's nice and easy to remember. But it turns out the physiologic orthostatic tachycardia varies with age. In young folks, and if you have small kids at home and you feel like playing science with them, measure their heart rates lying and standing. It goes up a lot. It's actually, it's huge, and they're perfectly well. And as they get older, it decreases. And so this became a problem. And so Wolfgang Singer, when he was a fellow at Mayo, he's now the president of the American Autonomic Society, went into the school system in Rochester, Minnesota, and did this assessment. And a whole bunch of teenagers actually had excessive orthostatic tachycardia that were perfectly well. And so they redefined the criteria several years ago that in kids 12 to 19, so under the age of 20, they needed at least 40. But even that, is not perfect, because an increase of 30 beats per minute in a 50-year-old woman is a lot more impressive than an increase of 30 beats per minute or 31 beats per minute in a 20-year-old woman, because it does decrease with age. So it's just worth keeping in mind. We have a line in the sand for the criteria, but it's actually a bit more nuanced. It's just hard to put nuance into criteria. So that's great. So we've talked about orthostatic tachycardia. We talked about the lack of orthostatic hypotension. That's all physiology. And I'm a human physiologist at heart, so that speaks to me, right? But that's pot. Not the marijuana kind, the other kind, right? But that's postural orthostatic tachycardia, right? But the key to POTS is the S. It's the syndrome, right? So these patients, to have POTS, have to feel unwell. They have to have chronic symptoms. These symptoms have to be worse upright and better lying down. Not all of them, but a preponderance. If that's not a dominant feature, not POTS. Everything I've mentioned up to now, so this group, I suspect, compared to yesterday, doesn't have POTS, is that correct? How many people don't have POTS? Okay. In the last 24 months, how many of you have had a good going viral infection? Really healthier bunch than I would have thought, right? I live in Canada, right? I'm good for a viral infection pretty much every winter. But, maybe the climate here is just kinder and gentler and doesn't happen, right? But so next time you get a viral infection, again, if you feel like doing home science, assess yourself against these criteria. Measure your orthostatic, tachycardia, your orthostatic heart rates. Look at the symptoms. And I suspect many of you would actually meet the criteria for POTS, right, based on just that. But the difference is that you're going to get better in a few days, right? So the key to POTS isn't that you have just that, but that it's chronic. It doesn't go away. And so initially they required at least 6 months of symptoms. Now some of the criteria have gone to 3 months. The truth is it probably doesn't make much difference. What you're trying to eliminate are the people that are sick for a few weeks, right? So it has to be chronic. And then the final thing is this has to be in the absence of other reasons to have orthostatic tachycardia. So if they're on stimulant drugs that are causing the heart rate to go up, they may still have POTS, but you can't assess it until you can get them off the drugs. If they have Addison's disease and they have no blood volume and that's why they're tachycardic, don't diagnose them with POTS, treat their Addison's, right? We're not trying to give an extra diagnosis. We're trying to account for something that doesn't have an explanation right now. So one of the challenges we found a few years ago when we were developing the Canadian Cardiovascular Society POTS statement was that there was a lot of misdiagnosis, right? And one reason is lack of knowledge. People didn't know about POTS, fair enough, right? But then there are people being diagnosed with POTS that didn't have POTS. Every one of us on the writing committee had seen this. And the question was why? And one of the things that occurred to us was that there were people that, for example, had the symptoms but didn't quite meet the heart rate threshold. And you could say, well, you don't have POTS, which is strictly speaking correct. But in many cases, what the patient hears is another doctor that doesn't believe me and thinks I'm faking it, right? And that's not necessarily what you were saying. What you were saying is you didn't meet, these are the criteria, you didn't meet it. And so some people would say, okay, you have POTS. Like I actually had a patient come up to me after a meeting in Boston, a patient meeting in Boston, went on for several minutes and then said, oh, I don't have tachycardia. I'm one of the POTS patients without tachycardia. Thinking, that's crazy, right? But why was she told this? Why was she told this? Probably to validate that something was wrong with her, right? And so they gave her the label. And so we said, well, that's a problem if you're trying to understand POTS and then you're including lots of things that don't meet the criteria. So we came up with an ecosystem of disorders to account for things where something's wrong, but it's not POTS. And so one of the keys was that we said, okay, if you don't quite meet the heart rate criteria, but you're very symptomatic, we called it postural symptoms without tachycardia, or PSWT. And this basically speaks to our lack of marketing creativity, because it really is a crappy sort of acronym. And if you can come up with something better, that's great. But the importance of it was that we wanted to offer a diagnosis that saying it's not POTS, but it's, this is something, and we have to figure out what each of these are. The other challenge is that there was a problem in the literature and in conversations with other physicians talking about POTS. Because some people, when they said POTS, they meant a fairly pure cardiovascular phenotype. They had the orthostatic tachycardia, they had lightheadedness, symptoms directly attributable to the tachycardia, and that was it. But other people, when they talked about POTS, were talking about patients that may have lots of GI problems that we're going to hear about today. They may have lots of pain issues. And let's say I treat their cardiovascular issues and their tachycardia and get that under control and fix those things. If that's the dominant issue, then I probably improve their quality of life. If that's not the dominant issue, if they have other dominant issues, then the impact on their quality of life will be less. And so it's important to sort of understand who you're talking about when you're saying this works or that works. It doesn't work. And so we sort of said, okay, well, there's POTS and there's POTS plus, or there's PSWT and PSWT plus. And we came up with some clinical criteria for what this plus was based on associated diagnoses or associated significant symptoms or comorbidities. Right? And it's not an exhaustive list. We just sort of, pulled it out of the POTS survey, which I'll touch on in a bit. And then when we actually submitted this for review, the reviewer said, this is sounding really complicated, all these diagnoses, can you create a flow chart for physicians? So we actually created a flow chart with a bunch of yes or no questions. And this is, by the way, this document is open access. So if you go to the CJC site or even the CCS site, you can pull it down for free. And if you like flow diagrams, you can sort of keep this in your pocket, but you don't need to use it, and there won't be a test. So coming back to POTS, so we talked about these common symptoms you have to have, and you can break things down in lots of ways, but I'm a cardiologist, so I tend to break things down by things that I could blame on the heart and things that I have a lot more trouble blaming on the heart. And so on the left are symptoms that in a tachycardia-related disorder seem plausible that the heart's the cause. The palpitation, the lightheadedness, chest discomfort, shortness of breath, especially exertionally. But on the right, there are a bunch of symptoms we see a lot that I have trouble blaming on the heart: mental clouding or brain fog, headache, nausea, tremulousness or shakiness. Right? And everything on top in the black on both sides are things that get worse with upright posture and better with recumbence. But then there are symptoms below in both sides that don't. So almost everyone has exercise intolerance. The overwhelming, almost universal is fatigue. So not everyone meets criteria for chronic fatigue syndrome or ME/CFS, but almost everyone is chronically fatigued. High proportion of sleep complaints, and that's not positional. We don't ask our patients to sleep standing up, right? But yet they still have problems. So what this speaks to is that while there's a strong cardiovascular component, this is actually a multi-system problem. It's not just about the heart, although it pains me to say that. Shown here are sort of representative tilt tests done years ago when I was at Vanderbilt with a healthy control subject, a Vanderbilt grad student on the left and a POTS patient on the right. And there are a couple of things to look at. So heart rate channel on top, blood pressure channel in the middle, tilt angle, so you can see when the table was up and came down on the bottom. The first thing is if you look at the blood pressure, the POTS patients don't have low blood pressure as a rule, right? If anything, I think the average pressure is maybe marginally higher, but it's comparable. Now, you could look at the trace. This is a continuous blood pressure trace. You could look at the trace and say, but it looks different. And it does, right? This looks a little like I did this morning when I woke up before my shower and I just couldn't get my hair to sort of sit down, right? It's sort of all over the place and spiky. And it turns out that actually, I think, is really important. I think those spikes represent sort of the autonomic physiology in terms of its attempt to maintain the blood pressure, but it's not low. The other thing to note, if you look at the control subject, is the heart rate goes up with tilt. That's physiology. But if you look at the POTS patient, they're just better at it, right? It went up faster and it kept going up. And that patient actually didn't make the full 30-minute tilt protocol. That patient told us to put her down. And when she did, her heart rate was almost 180 beats a minute. right? So I mean, that's not typical, to be honest, right? That's on the higher end, but we've seen patients higher than that, right? So there's a spectrum. And these patients felt very symptomatic. So we were rating symptoms every few minutes. If you look at the control subjects in black, basically they were asymptomatic. Every once in a while, someone would get symptomatic, then they'd faint, and they'd drop out of the collection, and the group would be asymptomatic again. In contrast, the POTS patients told me they were about to faint almost immediately, and then they kept telling me for 30 minutes. The interesting thing about this study is that a higher proportion of the POTS patients made it through or survived the 30-minute tilt than the control subjects. There was a higher rate of vasovagal syncope, fainting in the control subjects. Right? The lesson here is that POTS isn't primarily a fainting disorder. POTS is a feeling faint disorder. The patients feel like they're going to faint. A minority do faint, but it's a minority. It's not the majority. So for years, we had a sense of, we thought we knew what we knew about who got POTS, but this was based on our physiology studies at Vanderbilt that, my mentor and boss, David Robertson, would tell me that his skin would crawl if we had to enroll more than 12 patients in a study. So there are small physiology studies from Vanderbilt, from Mayo, and the question is, was that really representative? Did those patients that were willing to come and hang out with us at Vanderbilt and move into our research unit for 7 to 10 days representative of the broader population? And we didn't know. So we worked with Dysautonomia International, a US patient advocacy group, and created a large patient survey. And it was ethics approved at Vanderbilt. And right now we have over 10,000 people, patients or parents, that have completed the survey. And this is sort of from the first paper showing the who gets POTS, right? So similar to what we found, actually more so, overwhelmingly female, overwhelmingly white. In terms of age distribution, the most common age of onset was 14, right? Big pediatric, onset right around puberty. But there's a big tail, right? So just under half the patients develop POTS in adulthood. And again, this speaks to possible heterogeneity, right? It may be that this group that develops it around puberty is different than the group that was fine then and develops it later. So we have to be careful when saying POTS does this or POTS does that. There's probably different subgroups that behave differently within that. We had a laundry list of symptoms that we asked people to endorse. And what we found was the top few are what we'd expect for a tachycardia disorder: lightheadedness, tachycardia, presumably palpitation, pre-syncope. But then the next few were not. Headache, difficulty concentrating, nausea, memory problems in almost 90%. Right? So again, not just a cardiovascular disorder. The comorbidities that were commonly seen in this survey are listed here, listed in the prior slide, but highlights are that migraine headaches in 40%, EDS 25%, 25 to 30 is what we often see in other studies, so this fits with that. Fibromyalgia, 20%. Autoimmune diseases, so not one disease, but if you actually clump different autoimmune diseases together, it was seen in 16% of the group. Right? So this sort of speaks to sort of the importance of other things in this group that may contribute to the symptomatology and may need treatment. So when you have a disorder with so many teenagers getting involved at that stage, one of the concerns is education, because that's actually what teenagers tend to do. That's their job in life is to get educated. And there were lots of problems with education, right? So 90% of patients miss school. Almost 30% have been homeschooled. 25% have dropped out of school. Almost 40% had to either stop university or gap in university because of their health issues, right? And the challenge here isn't that they felt unwell for a couple of years around the time of their education, right? But if the education is disrupted, that affects not just those 2 or 3 years, but that affects the next several decades of their life. That affects the trajectory of the rest of their life, right? So it speaks to why it's critically important, especially in that age group, to try and get them diagnosed and treated, so at least to get them back where their schooling is not affected. What about quality of life? And this work was led by Kanika Bagai, a sleep neurology colleague when I was at Vanderbilt. This is not our data. This is data from the SF-36, which I don't know if you guys are familiar with this. It's a very generic health-related quality of life tool. It says nothing about POTS. But the utility of the SF-36 is it's so generic that it's been studied in everything, right? And so this is a couple of disorders from the literature that are viewed as having a poor quality of life: patients with chronic back pain and patients with end-stage renal disease on hemodialysis. And we just superimpose our data for the POTS patients here. So this doesn't speak to why. This doesn't say this is why they have a poor quality of life. It's just saying whatever it is, the patients perceive a quality of life that's comparable and potentially worse than patients on dialysis. And remember, patients on dialysis have to hook themselves up to a machine for 4 hours at least 3 times a week, right? So it's sort of disruptive to life, and the POTS patients are right there with them. I think a lot of patients, have been told that they have a psychiatric disorder. The POTS is a psychiatric disorder. We'll have data on that. I'm not going to speak about that because that's, I think, coming up right around noon, so got to make sure you don't leave. Okay, and so for the last bit, we'll sort of shift to the what to do, and this won't be exhaustive because Dr. Lau is going to be sort of talking about management this afternoon as well. I will say the investigations are not extensive. At least the mandated investigations are not extensive. It's recommended, the key is a good history and physical. It's actually, I understate it. The key is history, a little more history, do a bit more history, and then a brief physical exam, right? These are long histories. It takes a long time to sort of understand the journey and the nuances because it's often difficult for the patient to figure out which of the symptoms that may seem disparate are related and which aren't, right? So you have to sort of sift through that. Some basic blood work to rule out other simple reversible things are recommended. And this comes from both the HR Heart Rhythm Society statement and the CCS statement. A hemogram to make sure they're not severely anemic, make sure the electrolytes aren't grossly abnormal, make sure they're not grossly hyperthyroid, which can be treated and the tachycardia may go away quickly. Cortisol wasn't recommended, but might not be unreasonable. And when I say cortisol, it's sort of a morning fasting cortisol. And, I did internal medicine years ago, but I forgot all those stimulation tests and what the thresholds are. Really, what I'm looking for is a cortisol of 0, right? If the cortisol is on the low end of normal or just, I don't really care. It's not 0, right? What you don't want to miss is the full-blown Addison's causing this. And then orthostatic vital signs. It sounds like a silly thing to say, but I get a lot of referrals for patients with POTS where no one's actually measured orthostatic vitals. And it's really hard to diagnose an orthostatic tachycardia disorder without assessing, orthostatic tachycardia, right? So that needs to be done in a good 10-minute set. And then other things may be useful. There are other things you may want to do that aren't on this list based on the history, right? So if someone sort of comes in with a lot of sicca symptoms, you may want to think about Sjogren's and sort of looking at that. But we don't routinely recommend sort of shotgunning that to start. In terms of the treatment approach, I think the foundation for everyone that I see is non-pharmacological. And then we add drugs. And I want to be clear, that doesn't mean, that most people just get non-pharmacological and go away. I'd say the vast majority of the patients I see require medication. But it's not medication or non-pharm. It's, foundation of non-pharm and then add things as needed. And basically, this is the trifecta: dietary salt, and I probably should put and water. So salt and water, compression garments, and the role of exercise. So for years, we've been recommending, drink more salt and water. And the theory is that you'll expand your blood volume, right? Your theory is that you can sort of, perk up and retain a bit of the fluid. But actually, until a few years ago, there was actually no data looking at this. And so we got some funding in an NIH grant when I was at Vanderbilt, and we looked at this, and we brought in POTS patients for 2 one-week stints, where for the better part of the week, we fed them either a really low sodium diet or a really high sodium diet, and did nothing else to them until the end, where we did a whole bunch of assessments. And what we found, the short version is, it turns out salt does what we think it does, right? So by giving them a ton of salt, by pickling them really, we increase their blood volume. And blood volume, if you think about it, really consists of 2 parts. It consists of plasma, the liquid part, and it consists of red cells. All those white cells, platelets, and all that, they're important, don't get me wrong. They don't take up a lot of space, right? So in terms of volume, they don't matter, unless you have essential thrombocytosis, but they don't matter for the most part. One person had that, messed us up. But so they don't have that. And what it did is actually increase the plasma. It did nothing to the red cell volume. Now that's because we did it for a week. I think if we did this for a month, I think you'd actually see the red cell mass increase as well. right? But it increased the plasma. We stood people up and looked at orthostatic tachycardia and measured norepinephrine levels in the blood as a surrogate of sympathetic nervous system activity. It blunted that. So it's actually incorrect where I have the down arrow. It's actually probably should be a smaller up arrow. Norepinephrine still went up when they went from lying to standing. It just didn't go up as much. And the orthostatic tachycardia was blunted. It lowered the standing heart rate and lowered the amount it went up. Okay, so turns out it works. So from a practical point of view, this is what I do in my clinic, right? I try and get everyone to drink 3 liters of water a day. We made up the number, but it's a nice number. It's fairly safe. It's to ensure they're getting in enough that the kidney will see what they want to see. It's a lot. It's doable, right? But I have a very specific approach to getting people to do it. And the key in our clinic is that patients have to have a water bottle. They don't have to have 10 water bottles. They need to have one. And that one needs to be with them all the time. I tell them it needs to basically be glued onto your hand. If they come to my clinic and I ask them where the water bottle is and they say they left it in the car, they failed, right? It should be with them all the time. If there's a family portrait, I want the water bottle in the portrait, okay? Right? If they have it with them, and the nice thing about water bottles are it has one size. It could be 750 mils. It could be a liter. Do the math once. If it's 750, you need 4 of those a day. Done. You don't have to sit there and sort of say, well, there was a little glass, there was a big glass. It gets complicated. In terms of salt, between HRS and CCS, roughly 10 grams is recommended. I can't do the math. I can't sit there and add up, the amount of sodium and all the things and multiply it for the chloride correction factor and figure out if you're getting 10 grams. So I don't ask my patients to do that. I basically did the math once and said, okay, a teaspoon of salt is about 5 grams. So basically we're saying get in 2 extra teaspoons a day. That's a lot to take at once, right? But we don't need to take it at once. They need to get it in. So I get them to take that in the morning and put it in a little Ziploc snack bag or a container, and then through the day, add the salt from there instead of a shaker to their food, right? And they need to get it in. And for most people, adding it to food is the easiest, right? Most people actually like the taste of salt. If they don't, they need to find another way. So I have patients that add it to hot water and lemon juice and drink it. I get nauseated thinking about that. But I don't have to drink it. They have to drink it, right? I have some younger patients that add 1/3 of a teaspoon to shot glasses and do saltwater shots, right? It's not as good as a margarita. It doesn't have the alcohol, but it sort of gives you that feel, the tropical, whatever works for them, right? But they need to get that in. I don't tend to use salt tablets. I find a lot of people go to salt tablets early. The only advantage of salt tablets, uncoated salt tablets, is that you don't have to taste all the salt. So if they really dislike the taste, salt tablets may be better. But I think it causes more gut grief. Unless they're coated salt tablets, in which case they cause more wallet grief. They actually tend to be sort of expensive and add up in cost, right? But these are options for the minority. But for the majority, regular table salt works. I don't believe the pink salt, Himalayan sea salt, or kosher salt works better physiologically. But I will say this. If you're taking 10 grams of salt a day, that's a lot of salt. Taste matters, right? If you're just adding 3 granules a day, who cares? And so if the patient thinks the Himalayan sea salt tastes better, get the Himalayan sea salt because it's cheaper than any drug you're going to take, right? And if you're going to take that much in, you want to make it easy to get it in. Compression garments. So Kate Bourne, a PhD student of mine who's defending next month, actually, this is an in-lab study she did looking at lower body compression. And so it was a sort of a compression suit from the abdomen down to the legs. And we did repeated tilts. And what she showed was that compression decreased the amount of tachycardia on tilt, and both early, but also it decreased the ongoing increase that we saw when someone was tilted. In fact, in this study, we looked not only at full compression, no compression, but we looked at segments. So we looked at sort of abdomen, or basically a bicycle shorts compression, abdomen, upper thigh, and we looked at calf compression or leg compression. And what we found was that the abdomen, upper thigh was almost as good as full compression, not quite, and the leg compression was almost as useless as no compression, right? So when patients do compression and they come in with the socks, if they're pretty, that's fine, right? If you're doing it for but if you're doing it for your POTS, it's a waste of time, right? So not worth doing. It does prevent DVT, though. I don't want to, get the compression people angry at me. And what we found was that the more the compression blunted the orthostatic tachycardia, the heart rate increase, the more symptom improvement there was. And then finally, exercise. So a lot of our data comes from studies from Dallas, led by Chi Fu, published now, done probably 15 years ago, published shortly after that. And they did a heroic before and after study. They measured just about everything you could think to measure, just about, before and after a 3 to 6 month exercise program. And they improved fitness, they improved blood volume, they looked at MRIs of the heart, they put catheters in measuring venous pressures, they looked at sympathetic nerve activity, all stuff that physiology geeks like me find really cool, all stuff that patients don't care about, right? But it did decrease orthostatic tachycardia, right? So patients do measure that. And importantly, they also used the SF-36, and everyone that completed their protocol, which is not the same as everyone that started it, but everyone that completed the protocol reported an improvement in their SF-36 score, an improvement in their quality of life. Some a little, some a lot, but everyone improved. So our approach is that, you know, this is largely a focus on aerobic reconditioning, right? So, you know, my wife at one point got into sort of core strengthening and Pilates, and quite frankly, I can't do it. More power to people that can do it, right? Great stuff for you, not the same, right? So if patients say they're doing that and they're doing stretching, good for them, but that's an and, not an or, right? What we need for the POTS is actually about, you know, building up cardiac mass, increasing stroke volume. It's about aerobic reconditioning specifically. Frequency matters, right, for the training effect, right? So that means at least 4 times a week. I try and get patients to try for 5 or 6, mainly because life will get in the way, right? Even if they're really motivated and dedicated, something will happen where they'll miss a day or 2 here or there. And so if they're at 5 or 6, they're still getting 4. If they're at 4, they're down to 2, okay? And fairly quickly, every session should get to 30 minutes. Now, the most clever thing they did was that they forbid upright exercise in the beginning. If someone's heart rate is 140 minutes on the treadmill before you turn it on, that doesn't bode well for how long they're going to last on the treadmill, right? So the idea is to invest the heartbeats in exercise and not waste it on gravity. Now, eventually, you never have to actually get up. Like, you can do this forever. It's a great aerobic workout. They actually liked rowing machines. It turns out rowers have among the biggest heart. It's a good physiology thing. But you know, if that didn't work, recumbent cycles were an option. In Texas, swimming was an option. In Calgary, swimming pools are called ice rinks, right, in the winter, right? So not as good an option in Calgary, but probably here, swimming might be a good option too. And you never have to do anything else. The truth is most people want to, right? Because most patients, normal for them was things like running or treadmills or those evil elliptical things, right? And if they want to do that, they can do that afterwards, right? But in the beginning, don't let them do that, right? Unless they can get 30 minutes in. And this last point is actually the most important. And that is that when I first started telling patients to do this, they'd come back and say, it didn't work for me. And I had to go back to Chi Fu and say, well, what am I doing wrong? And she said, well, we said everyone got better. We didn't say when. Because it was a 3 to 6 month program. By the end, they got better. And it actually can take up to 6 weeks, 4 to 6 weeks before patients notice any improvement. Not total improvement, any improvement. And in that time, they may well feel worse. The post-exertional malaise actually, I think, does exist in this group, right? And they do get worse until they don't, right? So there's light at the end of the tunnel, but it's a long tunnel. And the nice thing is once they get to the point where they start to notice improvement, then patients tell me they feel worse when they miss exercise than when they do it. But in the beginning, you're asking them to do things that make them feel crappy. But if they hang in there, they get out of that. But it's a long slog. In terms of pharmacological approaches, and this will be the last bit, there are approaches that focus on increasing blood volume, and there are approaches that focus more on sort of managing the heart rate. Saline works acutely, right? This has been shown, 25 years ago, back to the late 90s by Jairus Jacob. If you look sort of on the far right, the orthostatic tachycardia was cut in half with a liter of saline. So if someone is acutely unwell, if someone's in emerge and they're debating whether to admit them or not, my advice is always try and give them a liter or 2 of saline and see. And usually they'll get better enough that they don't need to be admitted. The problem with saline is that while it does make people feel better acutely, it doesn't last a long time. And if you keep doing it, eventually you won't be able to get a peripheral intravenous catheter in, right? If you don't believe me, ask any oncology nurse. That's why they get really good at IVs, is that you keep doing it and the IVs get harder to do. And so the problem with chronic saline is a slippery slope, that after a while you lose the veins, then you put a PICC line in, that lasts 6 weeks. And then, patients feel better on saline, and inevitably you go down the, portacath central line approach. And it's the central lines that are the concern. It's the access that's the concern. And so most professional societies that have commented on this have it as a class 3, don't do it recommendation. But it has not usually to do with the saline, but the access. We looked at other approaches to try and increase volume transiently. And so we studied, when I was at Vanderbilt, acutely DDAVP, or desmopressin, right? So this promotes free water retention. This is, at 0.2 milligrams a day. This is a drug we give to 5-year-old boys who wet their bed. Tells the kidney to hold on to the free water, right? How bad can it be if we give it to 5-year-old boys? Well, the one thing is we don't tell 5-year-old boys to drink 3 liters of water, right? So you do have to be careful, because if this works too well, you can cause hyponatremia, right? So you don't want to convert a feel a bit unwell to I'm going to die, right? So if you use this, we do recommend checking the sodium periodically. I use it as a special event drug. Someone wants to make plans to go out with friends on a Thursday evening. They don't know how they're going to feel. If they take this and water, they'll probably feel okay that evening. I have colleagues that use it every night as part of treatment, and they actually run it, like the old Coumadin clinics. I don't know if you still have Coumadin clinics, because we've gone to DOACs largely, but where there's just a standing lab requisition. It comes in, a nurse looks at it to make sure the sodium's okay. And generally, the experience from people that have done that is, as long as people stick to 0.2 milligrams a day, it's been safe. But if you have a patient that says, man, this is so good, 4 would be even better, they can run into problems with hyponatremia, so just be careful. Mitidrin, so this is a squisher drug, right? A short-acting pressor that squishes arteries and veins. It works as well. This is from the same saline study. If you look at the far right, it lowered the heart rate, not nearly as much as the saline, but is a reasonable approach to decreasing orthostatic tachycardia. Beta blockers, I'm a cardiologist. When I trained, if I had a cardiologist who said if it moves, beta block it. We're used to that, right? But on the other hand, patients would routinely come to us saying, I don't tolerate beta blockers, right? That was the norm. So on our research unit, we were studying a whole bunch of different drugs like the DDAVP, and we studied propranolol, 20 milligrams, so short-acting propranolol, and we found that it was the most effective drug at lowering standing heart rate, lowering the orthostatic tachycardia, improving symptoms, right? Including in patients that told us they didn't tolerate it. And we couldn't figure out why, and it was actually our research nurse, Bonnie Black, who said, well, we tend to use low doses because POTS patients tend to be sensitive to medication. So maybe it's the amount of beta blocker. And in fact, when we looked at fuller beta blockade with 80 milligrams of propranolol, the symptoms started to get worse, right? So the key to beta blockers are not to fix the heart rate, it's to take the edge off the heart rate. So it still goes up, it's still abnormal, it's just not as abnormal, and that can make a big difference in symptoms. More recently, there's been a study showing ivabradine, which is a funny channel blocker that works on the sinus node without all of the other beta blocker effects. Also improved heart rate and improved quality of life in patients with POTS compared to placebo. We're actually doing a study right now comparing propranolol to ivabradine to placebo, but right now there's a bit of data that propranolol is better than placebo, a bit of data that ivabradine is better than placebo for POTS. We wanted alternate approaches, so we looked at seeing if we could increase the amount of acetylcholine, think this might have more effect on the vagal side, the parasympathetic side, than on the sympathetic side. And it turns out in our sort of study environment on the Clinical Research Center, it worked. It improved symptoms, it lowered heart rate. The truth is it's not nearly as potent as beta blockers. It's often a good adjunct, but I wouldn't rely on this alone. But there is this vague, nebulous, feel better sense, and it's hard to pin down what it is, and part of it is acetylcholine is everywhere. It's a neurotransmitter through large parts of the body. And it may even help constipation, but more to follow, or may not. The final drug class I'll talk about is a drug that I want you to be cautious about using or not use. And that is that, there are a lot of drugs on the market that are SNRI drugs, or more pure norepinephrine transport blockers, which is what the N is, right? So this is a clearance transport in the sympathetic neurons, When you release norepinephrine, this is the way they get rid of it. And so if you block this transporter, you effectively are increasing the bang for your buck every time your sympathetic nerve fires. You're effectively increasing sympathetic tone. And so we were concerned about that, and we tested atomoxetine, which is the purest NET inhibitor in North America anyway. It's Strattera, it's an ADHD drug that's on the market. And we found that it increased the heart rate, seated and standing, it increased the orthostatic tachycardia, and it worsened symptoms in the group overall. It's the only drug we studied that did that. Right? So the lesson here is be cautious in patients with SNRI drugs. SSRIs are okay. They don't do this. It's the end part that you have to be wary about. So these are drugs like venlafaxine. These are drugs like duloxetine, certainly atomoxetine, reboxetine in Europe. Right? Just be careful with them. And finally, just earlier this year, it said 2023, that was a preprint. It actually only got published just 2 months ago. There's a study out of Oklahoma looking at vagal nerve stimulation in POTS. It's a small study. I've been in talks with Dr. Stavrakis about actually potentially putting in a joint grant to NIH to do a larger study, but it's promising as a treatment, and it actually lowered the heart rate fairly early and maintained that during the 10-minute tilt. And we think its effects may be related to decreasing inflammation. I think it decreased TNF alpha levels in this cohort, but there wasn't as extensive an inflammatory panel, so more to follow. So with that, I'll stop. The take-home messages are that POTS is a chronic disorder associated with significant functional disability. It's a syndrome. It's not a disease. The implication is it's not a thing, it's a bunch of things, right, with a common end phenotype. The treatment principles involve exercise, volume expansion, heart rate control, and I didn't talk about this, but manage the living with a chronic illness, right? I mean, one thing to think about is, and I think doctors do this, I think patients do it even more. They want to know if this is, basically a body problem or a mind problem. And the truth is, it's a chronic illness problem, right? And these patients, I've cured no one with POTS, right? I've treated it, but I've cured no one. They're going to have this for the rest of their life. They need to learn to live with it. And some people do that well and others don't. And it doesn't matter how they do it, but you need to give them permission to do it. It could be religion, it can be yoga, it can be those coloring books, which I really wish I invented. It's kind of cool, the mindfulness coloring books. Whatever works for them, but give them permission, because otherwise they may want to avoid that because they think they're then dismissing that it's real. Thank you.
Thank you very much. Great presentation again. We've had a few questions come in. I might just start with where you finished off there about the heart and mind connection. So we've had a physician who has written in saying that they are starting to learn about diagnosing and managing POTS. And they're finding that a significant number of the population that they're seeing doesn't meet the heart rate criteria, but has symptoms consistent with POTS. Yep. And also come with a lot of anxiety. So what are your strategies for managing anxiety? Is this something that should happen first before we try some POTS-specific treatments? Or, where do you see management of anxiety in all of this?
Well, so, I'm going to actually answer the other part of that question first, and that is they don't meet the heart rate criteria for POTS. So this is someone who would fit into the PSWT group. But even that's probably not one group. So there are people whose heart rate goes up 5 beats a minute, right? And targeting the heart rate in that group is probably a waste of time. There are other people whose heart rate goes up 27 beats a minute, so they don't quite meet the criteria, but it's more than normal. And I think for those patients, using the approach of the volume expansion and sometimes even blunting the heart rate with drugs actually is effective. So actually, while I wouldn't label them that way, because if you're following the group, it's misleading, I think the treatment approaches that we use can actually translate fairly well if you're just short of the criteria. And the issue about anxiety, this may be a better question for the better Dr. Raj coming up later. But I will say two things. One, I've cured a lot of anxiety with propranolol. It's actually a great anxiolytic. So I'd be careful about that anxiety. Two, the patients so first of all, there are POTS patients that have anxiety disorders, just like there are heart failure patients that have anxiety disorders. So it's perfectly possible that needs to be treated. But a lot of the generalized anxiety is actually, I think, frustration at being ill and not being diagnosed. And so I guess what I'd say is, I'd make sure that if you want to treat the anxiety, it may need to be done, but make sure it is anxiety before you do that.
Yeah, absolutely, thank you. Another question, I'm seeing more carotid ultrasounds, especially in patients with migraine, being reported as fibromuscular dysplasia. Is there any evidence that POTS patients have higher rates of fibromuscular dysplasia?
So I want to say no, or I'm not sure, right? I mean, what I'll say, the beauty of new tests or new findings are that it takes a while to figure out what's normal and what's not. I mean, I'm not quite old enough to remember when echo first came out for cardiologists. That predates me a little, but I am old enough to know that literature that when echo first came out, almost everyone had mitral valve prolapse because people didn't appreciate that the mitral valve always prolapsed a little physiologically. And they had to redefine the criteria for what was mitral valve prolapse afterwards, right? So the question is, how significant is this fibromuscular dysplasia? And what it does, I have strong doubts it does anything related to POTS.
Yeah, okay, thank you. Another question about whether you're aware of any evidence linking POTS to EEG proven focal seizures. So sometimes we see seizures with normal EEG. If you have an abnormal EEG, but these are unresponsive to anti-seizure medications, reduce with propranolol and midodrine. Are you aware of any pre-existing evidence that there is this link between proven seizures and POTS?
So no, I'm going to do a no but, right? So the short answer is no. The longer answer is, EEGs are interesting, and it also depends, EEGs are like real estate, right? Seizures are like real estate, location, 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 right? So there are definitely areas in the brain that trigger autonomic activity, right? So typically insular cortex, amygdala. So if this is sort of more temporal-ish, I'd wonder about that. The challenge is these are deeper structures, and so they may or may not be missed on some EEGs, right? If they don't respond, the treatment for them often is anti-epileptic. So I'd actually, if that really is there, I would actually try different anti-epileptics.
Yeah. Yep. Great. Thank you. We've got a couple of questions on the exercise study that you presented. It's from 2010. Is there any more recent data in larger groups that confirms these findings? And a follow-up question to that around the high dropout rate that was demonstrated in that study. So I think from memory it was around 30 to 40% off the top of my head. Do you think for some individuals exercise might not be effective?
So I think so it's sort of a multi-question thing. So the first was, were there follow-up studies? So certainly from that group, that was sort of an in-house study they did in Dallas, and then they did, at least two other studies. But one study was actually a decentralized study where they had patients work with their local physicians and got the exercise diaries and basically did basic evaluations of orthostatic tachycardia and quality of life. So there are data more broadly that it worked. I think the compliance in that larger study, the decentralized larger study, was in the 60% range. I guess how you interpret that depends on where you stand, right? I mean, the truth is that I actually think that compares favorably probably with exercise studies in pick your favorite disorder, post-MI and heart failure, right? Exercise is hard to do. Quite frankly, if exercise were easier to do, I'd do more of it, right? So I don't think that those numbers are that bad.
Yeah.
Do I have some patients that aren't able to do it for different reasons? Absolutely.
Yeah.
Sometimes it's about the exercise. Sometimes it's about the comorbidity. So especially in the patients with hypermobile joints, I'd say most are able to do it, but it depends on where they're hypermobile and what they're doing. And it's sometimes a matter of modifying and finding ways that are better tolerated. Water exercises tend to be better tolerated. You have to be really careful getting out of the water, right, in that group, right? So it's a matter of finding a way, but are there people that can't do it? Absolutely.
Yeah. Yep. Are there any special considerations for patients with POTS who are also being treated for ADHD?
My sense, I'm not sure if these are related, but my sense is that a high proportion of my referrals right now are patients with ADHD on stimulants, right? And so I think the special consideration boils down to, one, for the diagnosis, we need to get them off the stimulants for at least the orthostatic vitals. But in terms of afterwards, life is about, actually, let me take a step back and get philosophical. When I was younger, a neuro physician, I thought treatment was about finding the best treatment. The longer I do this, what I've learned, and this isn't about POTS, this is everything, and arrhythmia management as well, the best treatment is often the least bad treatment, right? We're actually taking, a series of competing risks and we're trying to sort of, make the best of it. And so stimulants will make the tachycardia worse, period. But if the trade-off is that they're able to function, and that's the only way they're able to function, that might be the price that they're willing to pay and they have to pay. And if they're willing to pay it, who am I to say, no, you can't pay it, right? We can try and use beta blockers to try and, or evaporating to try and blunt that. It's not that, we'll walk away and not treat them. But there are limits to what can be done. And ultimately, they may have to decide, I'm willing to put up with these palpitations and feeling icky at this level because I can think in a way I can't otherwise.
The trade-off.
The trade-off.
Yeah. We have lots more questions, but sadly we're relying on footy tackles from here on in to have those answered. Please join me in thanking Professor Raj.
Thank you.